everybody. Welcome. Thanks so much for joining us today. My name is Nicole Lamberson, and I'm a physician assistant. I also volunteer doing outreach for the film, Medicating Normal, and I host conversations like this one today. Our guest today is Jaden Brandt. Finally, thanks everybody for your patience with having him on and me being ill. I really appreciate it. Jaden is a community pharmacist and clinical teacher at the University of Manitoba's College of Pharmacy. He completed his pharmacy training in 2013 and then a Master of Science in 2019 on the pharmacoepidemiology of benzodiazepines and Zdrugs in adults, a thesis resulting in 4 peer-reviewed research publications. Since then, he has served as a clinical advisor at the Alliance for Benzodiazepine Best Practices, which is a nonprofit organization with the purpose of improving safety and efficacy around benzodiazepine prescribing. He has specific training and interest in psychopharmacology, population health, knowledge translation, and pharmaceutical policy. He has successfully worked with many patients and their prescribers to develop collaborative tapering strategies to improve their quality of life by reducing ongoing harm from prescription psychotropic agents. So, hello, Jaden. Thanks so much for joining us today.
Yeah, thank you very much, Nicole, and thank you for the very kind introduction. I thought that was very accurate to my current pedigree.
Yeah, sure. So I guess just to start, is there anything I missed in your introduction? Is there anything about your training or what you do that you want to kind of give people?
Sure. So, I'm very active on a number of fronts within my profession. I do remain active on the front with psychotropics and benzodiazepines. That is my kind of personal, and it has kind of become my professional area of expertise. However, I'm still very much kind of a junior career investigator and professional who's still kind of finding my own kind of path. And so I'm currently a PharmD student at the University of Alberta. I do work with a few other kind of not-for-profits related to the pharmacy profession. I'm still involved with some projects with the Alliance. So, and I've just actually, this is my new office space for me. I'm starting a new job doing home care pharmacy visits. So it's much more clinically involved and intensive, and I believe that it'll provide me ample opportunity to work more closely with patients and their providers in terms of managing psychotropic medication in particular, but all medicines generally to improve their health. Mm-hmm. So that's kind of just an update to where I'm at right now.
Home care pharmacy is just in Canada, what you go to the person's house?
Yeah, so it's actually extremely unique. And it isn't a very common form of employment for pharmacists. Normally, we think of pharmacists as being employed in community pharmacy, and that is still probably 70 to 80% of pharmacists are employed in that capacity. This is more of a novel kind of entrepreneurial venture. It has been a successful business now for a number of years. But I'm very new to the team here. So essentially, we do provide care at home. We visit people in their homes and work with their providers in terms of managing their medication, detecting drug therapy related problems, and working with them to both ensure best outcomes for their disease state management, their kind of longevity, and their quality of life.
Okay.
So we do a lot of disease and drug therapy monitoring in capacity sometimes where patients aren't necessarily always able to make it into a physician's office when it's kind of overstrained, and we do have a strained healthcare system in Canada currently, as you can appreciate, and I believe it is in many ways similar in the US, even though our systems are quite different.
Yeah, I remember when I was really sick in benzodiazepine and psychotropic drug withdrawal myself, that there were people like in, Australia who had these in-home type visit things. And I was kind of jealous, like, I have agoraphobia. It would be great to have someone come in and sort of assist in the withdrawal.
Yeah, absolutely. And it makes people far more comfortable when you're visiting them in their home. They tend to open up a little bit more. We don't have the pressure. The confidentiality is more secured and guaranteed compared to a busy retail environment where pharmacists do our utmost and our absolute best to maintain those boundaries, but it can be challenging in certain environments.
Yeah.
In Australia, you make a good point. I believe home medicine reviews, at least they were. I believe they maybe still are, but not being in Australia, I can't speak with certainty. But it was a subsidized service by, I believe, the federal government or the national government there.
Yeah.
So yeah, it's been around for a while. It's new to me, but I certainly anticipate this as being a very exciting and hopefully very successful career venture for me.
Okay. So let's move into the benzodiazepines and Z drugs, since you did, a big thesis on them. And
Yeah.
I'm just wondering how you became interested in them in the first place, in their risks and harms and tapering and all of that.
That is an excellent question. So I was always very interested in psychopharmacology. I kind of discovered that how drugs work on the brain was fascinating to me as a pharmacy student when I was much younger. Learning the clinical use of medication in terms of optimizing outcomes for patients, particularly in psychiatry and mental health. I quickly noticed when I graduated and I moved back to my hometown, which is in northern Manitoba. It's a smaller community called Thompson. I started noticing the disparities between the perfect world of prescribing that we learn should occur in the classroom and then what is actually happening out in the real world with many of our patients. So it kind of prompted me to kind of investigate that gap and really understand, first of all, how big that gap is. Like, to what extent are we not prescribing benzodiazepines within the parameters of guidelines or protocols that we know to be safe and effective for anxiety and insomnia? But it also wanted me to investigate why this gap is even occurring in the first place. Like, what are the behavioral, social factors, the complexity of patient care, and maybe our environments that we work in that are resulting in possibly inappropriate or unnecessary long-term treatment with these medications. So that resulted in me coming back to the University of Manitoba in 2016 to pursue a master's degree. I did work in pharmacoepidemiology, so that is the work of understanding patterns and determining a number of outcomes, whether it's related to effectiveness of drugs or adverse outcomes, but we're essentially looking at larger population data and trying to draw sound statistical scientific inferences from this data. So every jurisdiction and location is a little bit different, of course, in terms of what the policies are, the population. I did work on looking at benzodiazepines in Manitoban adults, so I didn't look at the pediatric population, but all patients that have an ICD, or what's called an international classification of disease diagnosis coded for either a mood disorder, an anxiety disorder, or insomnia. Mm-hmm. And I looked essentially over a 15-year period from 2001 to 2016 to kind of evaluate drug utilization trends and issues maybe arising with benzodiazepines and Zdrugs. Mm-hmm. And then delving into that, I also did some work in terms of understanding maybe why studies are different and where we can maybe improve estimation of benzodiazepine use in populations. So that was another paper that I was able to kind of successfully publish, and looks at maybe integrating both things like defined daily doses, or something that is an internationally recognized metric, with the more kind of clinically useful diazepam milligram equivalents. Hopefully that kind of is a broad overview, but I can definitely delve into the research on deeper levels. I just don't know how useful it is maybe for our audience. But
yeah, sure. I mean, I was going to ask, the thesis that you that it says in your bio, it resulted in 4 research publiblications. I mean, are there any like significant findings that you can kind of summarize?
So I can kind of tell my journey, and the other thing with me doing a master's degree and successfully completing it with that level of work, it did provide me with the willingness and the motivation to continue this work after graduation, and that has resulted in me working with not-for-profits, excellent ones such as the Alliance for Benzodiazepine Best Practices. But we'll maybe get into that. But some of the main kind of core distillations of my thesis. The first was they're all peer-reviewed publications, many of them open access. The first was looking at the causality of various adverse outcomes from both randomized controlled trials, observational studies, systematic reviews, and looking at the various harm associations from benzodiazepines and Zdrugs. So this was a broader review article, a narrative review article, but it really tried to understand to what extent are these agents actually causing or at risk or increasing people's risk for things like motor vehicle accidents, falls fractures, dementia, and then some that are people don't necessarily think about, such as infections, or there's been some studies in Taiwan about pancreatitis. There have been studies on cancer. So some of these that are more molecular or experimental science-based studies, but I really wanted to understand to what extent these agents have been investigated in terms of causing these other harm outcome measures. Ultimately, the main things that this research paper kind of produced is that we can really only soundly conclude at this point in time that benzodiazepines cause cognitive impairment, increased risk for overdose, especially when combined with opioids and alcohol and such, and increased risk of falls fractures and motor vehicle accidents. The other harm associations that are a little bit more speculative, such as causing cancer, infections, there might be a kind of a biomedical or a theoretical basis for these things, but they haven't been substantiated. So I really take the tact of trying not to alarm patients or make them too worried unnecessarily when the evidence isn't necessarily there yet to strongly conclude that they are causing some of these more significant harm issues. It could be a positive motivator for many patients, but I also think that it's a fine balancing line between telling them, right, that it's going to increase their risk for cancer, dementia, things like that, when that isn't necessarily the case.
Can I ask you something about that?
Yeah, please.
Increasing the risk for, cancer, dementia. When you're trying to prove something like that, could it be secondary? In other words, like, we know that you may be more at risk for cancer or dementia if your sleep is terrible.
Absolutely.
And if the benzodiazepine destroys your sleep or causes insomnia because you have tolerance or something and you're having this rebound insomnia or terrible insomnia from withdrawal, is that in studies, does that point back to the benzo though? Or is it the middle thing, which is the insomnia? You know what I'm saying?
Yeah, I know what you're saying. I think that is kind of the crux of the issue and is an excellent question. So the issue of confounding factors, as we call them in epidemiology, is an extremely difficult thing to narrow and pinpoint the exact effects of the medication compared to various lifestyle issues, various other kind of biological differences between people, other baseline risk factors such as other comorbidities and such. So I think you raise an excellent point. Part of the main difficulties with the dementia research has been the fact that we have these issues of confounding by indication, for example. So this is a situation where maybe people are starting to exhibit early behavioral and psychological symptoms of dementia, but they haven't actually received a dementia diagnosis in the claims data or the administrative data for epidemiologists. Mm-hmm. And then they get started on a benzodiazepine, and then the dementia diagnosis comes later. Mm-hmm. And then it appears that the benzo caused the dementia when in fact the reverse is the case. They were already starting to experience those brain state changes and behavior changes long before. So that's you raise a good point. When it comes to things like infections and cancer, at this point, it's more looking at some experimental data, but there is also some meta-analyses and randomized trials. One of the important FDA meta-analyses from many years ago by Dr. Daniel Kripke showed that there was slight increases in various infections among Z drug users. But there's also the issue of that many of these patients could also just be different than your average patient with that doesn't receive these drugs, right? So it's and different maybe in important ways of having other medical illnesses that then cause the insomnia, and then they result in the drug being prescribed. So teasing these details out is really the one of the most difficult things with determining the science in terms of the harm.
Yeah.
But definitely, I think the key takeaways from the first paper, the review article that I authored with my advisor, was that they definitively do increase risk of vehicle accidents, falls, fractures, cognitive impairment, and that these need to be evaluated on an individualized kind of patient basis as well. But definitely prescribing them without the proper care and thoughtfulness, we're putting people at risk potentially.
Okay. So are there other papers that you want to sort of
Yeah,
say?
yeah.
I know I interrupted. Sorry.
No, that's fine. And I mean, I do hope not to kind of overtalk or spend too long on one topic, because I think
Sure.
we can there's plenty of other issues that we can delve into.
Yeah.
The other papers, one was trying to, as I may have indicated previously, trying to reconcile the issue that many drug utilization studies on benzodiazepines only maybe use the defined daily dose metric, and they don't adjust for equivalencies between benzodiazepines. So seeing that there's so much use, say in, who knows, maybe a nation in Europe or in South America, and then trying to compare that to Canada or the US, it might be difficult if we're not adjusting for equivalencies among benzodiazepines that are being used in those countries. So there might be different benzodiazepines that are used in Costa Rica or Spain than the US, and it might appear that their use is much greater or much lower than ours. But if we're not doing the proper dose adjustments and equivalencies based on, say, a reference benzo like diazepam,
Yeah.
then the studies and their reporting can kind of skew researchers' conclusions internationally. If that makes sense.
Yeah.
And then the other two papers were predominantly based on the Manitoba adult population. So it used data from, we have an excellent, and I don't mean to brag, but in Manitoba, we have very good administrative data for prescription use and all contacts with the healthcare system, because we have like a provincial insurance registry that everybody is a part of, and the data is very longitudinal and consistent. We can look at large populations. So my study looked at over 200,000 Manitobans over 15 years that had anxiety disorders, mood disorders that may have indicated kind of concurrent anxiety where a benzodiazepine was initiated, or sleep disorders. Sleep disorders aren't usually well captured, but given that Z drugs are universally just used for insomnia alone, we typically can use that as a proxy for insomnia. But one of the key takeaways from those two studies, the first is that Z drug use over benzodiazepines, so zopiclone in particular in Manitoba, from the years 2001 to 2016, and I suspect it's sustained itself since then in the the last 8 years since, but it has risen by 300%. So I think what that really tells us is that there are a lot of changes in our society, a lot of maybe lifestyle issues with smartphones, other factors that are impacting people's sleep. We also just have an aging population, and as we all can appreciate, as people age, their sleep quality does decline. So there are a number of converging factors that have resulted in a very large increase and sustainably higher levels of Z drug use than we've seen decades ago.
Wow.
Whether that's a good thing or not, I mean, that's not necessarily for me to say, but when they're being used long term and they're not being appropriately managed in the older adult population, we can understand where those risks of falls, cognitive impairment, and then even the more kind of hypothetical ones that were mentioned in the paper that haven't been proven could still be concerning. And then the very last paper that I published for my thesis looked at the duration of long-term use among patients who are just initiating a benzodiazepine for the first time, that have an anxiety disorder or mood or sleep or insomnia. And we found that based on the most common definition of long-term use among a systematic review that was published in Europe that looked at, I think it was close to 40 different drug utilization and retrospective cohort studies, the most common definition of long-term use is 180 days, so 6 months. Now, for many people clinically, both patients, physicians, pharmacists, we would say that's maybe even a bit too long. Some of us would think maybe 2 months or 12 weeks could be long-term use. So there is variation in that, but my study did show that if we define long-term use as 180 days, only about 1 out of every 20 patients who get started on it for the very first time use it that long. However, we don't know the effects of their longitudinal life course with repeat benzodiazepine use episodes, with repeat exposures if they eventually then go on to long-term use. That did appear to be the case from looking at the data and some of the supplemental outcomes. And then there are other factors that have been contributed to long-term use that we were able to kind of look at, such as lower income assistance, residential mobility. If people are moving a lot, might have a small predictive feature for longer term use, whether they were married or not. So some of these social factors were actually did provide some level of predictive capacity to the model. So marriage was actually protective, meaning that if you were married, you were slightly less likely to be a longer term user.
Mhm.
If you had a lot of residential mobility and were moving a lot in the last number of years before getting started on your benzodiazepine, you were more likely to be a longer term user. If you were on income assistance, you were more likely to be a longer term user. If you were an older adult, in our case, surprisingly, it was males, I believe, if I'm not mistaken, that were longer term users, but that's not always consistent with the data. Ultimately, this is one study among many, right? And these benzodiazepine studies have been conducted for decades, and there is often similarities between the findings, but they're not always the same. So my study isn't necessarily generalizable or definitively kind of conclusive, but I do believe it does provide some insight for kind of your Western nations that are dealing with kind of this silent benzodiazepine epidemic that is underlying maybe the opioid issue as well.
Yeah. So somebody in the audience has a question that
Yeah.
has to do with you talking about the equivalences, and they're asking why the World Health Organization or similar doesn't give an equivalence table, or is there something, across the board?
Yeah, that's a good question. So I can't speak on behalf of the World Health Organization. I know that as an ambitious master's student, I did actually email them this idea, and it's not an original idea. Like this second paper that I produced on benzodiazepines, and it's called let me just see here, translating benzodiazepine utilization data into meaningful population exposure, integration of 2 metrics for improved reporting. So that's the title of the paper. But in terms of the reason why the WHO doesn't do that, it hasn't been part of their methodology for decades. They've always used what is called the ATC, or anatomic therapeutic classification system, along with defined daily doses. Defined daily dose being the usual maintenance dose for, I believe, the most common indication for a drug. Now, part of the issue with that is the defined daily dose for clonazepam, based on epilepsy, is, I think it was 8 milligrams, which is a whopping dose per day, especially for patients that are using it for anxiety disorders or off-label for insomnia. So, ultimately, using the DDD would vastly underestimate clonazepam exposure compared to, say, lorazepam or diazepam and these issues. So that was one of the main problems. Some of these same systems of equivalency values have been proposed in the research previously on for morphine milligram equivalents or opioids for other drug classes. I think perhaps the main reason that they haven't yet been adopted is because they're not yet fully standardized on an international level.
Mhm.
So we do see different equivalency tables between benzodiazepines from one source to the other. So how do we reconcile one source with another source? I think that could be an idea for future research, like a large international study or survey looking at what psychiatrists that use benzos regularly, or family doctors and pharmacists. If you can get a large enough sample size of uh, um, clinicians, and maybe even to some extent there could be a patient component there as well that provides input, we can all kind of come to a large international consensus on what the equivalencies are.
Yeah.
But there's also variations between ethnic groups with possible differences in pharmacogenomics, and so it is challenging. But that's why in my paper I recommend that people report both. They report both the diazepam milligram equivalents, their source for it, and then also the defined daily doses.
Yeah. And maybe it's just too like what the patient feels is covering their withdrawal when they cross.
Absolutely.
Yeah.
Absolutely. Yeah.
Yeah.
And I think that's a core feature. When it comes to the clinical management, I really do think that, and I believe it is becoming more common anecdotally from my personal experience, but also in the literature, that patients are becoming more involved, and there is more of a shared decision-making paradigm and framework that is being supported and encouraged, so that patients can kind of adjust their tapering, and that it's just kind of overseen and monitored by their providers.
Yeah. So I want to talk a little bit about your pharmacy training.
Sure.
I know, having gone to PA school myself and talking to like Dr. Christy Huff at BIC, who trained as a cardiologist, both of us don't remember a lot of training on benzodiazepines, especially like the physical dependence component and the exit plan and the withdrawal. So I'm wondering if in your pharmacy training you had a lot of that or not really.
Yeah, no, that's a good question. And I mean, it takes me back to my undergraduate years when I was doing my BSc.Pharm and doing my PharmD now. I do think that there's definitely changes in the curricular strategies and such. We did cover benzodiazepines to a large extent, but mostly for the appropriate prescribing and initiation of them. Even though we did kind of have a fair degree of extensive training on drug withdrawal, it really isn't until you do a master's degree or you do something at a higher level that you realize all the things that you didn't necessarily know that your average kind of clinician would get in their training. So the issues of say protracted withdrawal, newer concepts that are emerging in the literature, such as kind of like a benzodiazepine injury syndrome or bind, benzodiazepine induced neurological dysfunction. Some of these concepts, they're not widely accepted at this point, and the constructs need to become more valid. But when we listen to our patients and really understand their experience, we realize that we need to be open-minded and investigate this as a possible truth. And then how do we improve the science and learn from that? So there's been a larger focus, I think, in the curriculum of pharmacy in general, pharmacy students and the continuing education of pharmacists on deprescribing. Deprescribing has been a huge focus probably over the last 5 years, maybe a bit longer, but it's really come to the forefront with newer guidelines and such. So there are deprescribing guidelines for benzodiazepines, as you can appreciate. From my expertise and experience working with patients, I don't think that they're always readily useful in all situations, and that doing like kind of your conventional cookie cutter approach of reducing by 25% every 1 to 2 weeks for the first 3 reductions and then going 10%. I don't think that that's as feasible for many patients as we would maybe like to think it is.
Yeah.
So I don't think that pharmacists necessarily get that level of detailed experience. And part of this is, as long as our fellow pharmacists and prescribers and physicians, PAs, nurse practitioners are willing to kind of be open to experience and maybe learning new things on the job, this new knowledge will kind of emerge and become ingrained within our practices, if that makes sense.
Yeah. So I don't know how different it is in Canada compared to the US, but when I sort of reflected back on my own polypharmacy journey, and particularly being on two benzos and a Z drug at the same time, I kind of wondered, like, where was the pharmacist in all of this, right? Like, why
Yeah,
didn't they advocate for me? Or
that's it. That's a good question. So I think that part of that is, it is perhaps, and I can't speak for my entire profession, because like anybody, you have good professionals and professionals that are slightly less competent.
yeah,
In every profession you have. So by and large, I do think that the pharmacist maybe should have been there. I can't speak to your circumstances and really understand
yeah,
maybe why they weren't. I do think that pharmacists, and this is, I believe, largely a truism from talking to my peers, um, are sometimes, we're kind of relegated to the sidelines, or we're not necessarily encouraged to be as involved in the patient care by some more kind of paternalistic prescribers.
yeah,
Maybe your older doctors who are unwilling to collaborate. I think that that is falling kind of further aside, and we do see more and more involvement of pharmacists working interprofessionally in different settings. I think my early experience here at this home care setting has shown that to be the case. That prescribers are very open and willing to be involved, and um, I think that it's also, if you're in a very busy community pharmacy setting and things have been always the status quo or the same for a patient, we don't always know what is happening in the background in that patient's life unless we ask. And sometimes we are reluctant to ask.
yeah,
Mental health is a very difficult thing for many patients, and it is hard to talk about it at the counter when you're getting your drugs.
yeah,
So, and sometimes even trying to delicately engage somebody in those discussions. If you're a new pharmacist and you're not, you're still learning what does and doesn't work in terms of communication styles and how to interact with patients, and everybody has a different personality.
mhm,
All it takes is a few, I think, maybe negative interactions or where things didn't go well, especially with benzodiazepines, and then you take a more hands-off approach, where
yeah,
you are realizing like, oh, this patient doesn't want to talk to me, therefore I won't try to help them with their benzo.
yeah,
And that is the wrong attitude. I don't encourage that.
yeah,
Uh, but like any professional, we need to kind of roll with the punches, so to speak. And if patients are having a bad day and they kind of take their frustrations out on us, not to take it personally, but to try to learn from it and maybe work with them in the future.
yeah. Well, in the age of social media too, we kind of get a look into things sometimes. There's a lot of physicians on Twitter and TikTok, and I've actually seen an MD on TikTok saying, like, this silly pharmacist sent me this fax, asking why I was prescribing this, and I wish they would just fill the drug
Yeah.
and leave me alone.
Yeah.
I shouldn't have to explain myself, type of thing.
Yes, and I think that that does happen. I'm doing my utmost to be as diplomatic to both
Yeah.
sides as I can possibly be. But there are stubborn people out there in the world.
Yeah.
I don't think that it engages or enables patient care when um, you kind of treat your fellow professionals like that,
Mhm.
especially when you publicize it on social media. I think that it only makes you look bad in that way.
Yeah.
Unfortunately, it doesn't show that you're an endearing advocate for interprofessional care and working with fellow providers who have a unique education and expertise that is specific to medication.
Yeah.
So, I definitely defer a lot of issues of uncertainty when it comes to uh, certain disease state parameters or for complex cases back to the physicians. That is their area of expertise.
Mhm.
When it comes to the medications, they're ultimately responsible as the prescriber, but I also like to think that I'm ultimately responsible as a care provider and ensuring that their medications are optimized. So let's all work together and be on the same team
Yeah.
and make sure that the patient is a part of that entire process as much as it is within their capacity to be, and as much as they're willing to be, because it's their body, it's their life that we're trying to deal with and help.
Yeah.
And so
I agree. The whole collaborative approach, everybody should be, have a say and communicate and be involved.
absolutely,
Yeah. I want to ask about this critique that you wrote. There's an
yeah,
international task force on benzodiazepines. Most people in the benzodiazepine withdrawal community are probably aware of them, but maybe
mhm,
they don't know, who they are or what they're all
sure,
about. And then you came along and wrote this critique. So I'm wondering too, like what inspired you to write it? And
yeah, I'd be happy to. So as a graduate student, I was an admirer of a number of the psychopharmacologists and academic psychiatrists on the ITFB, which stands for International Task Force on Benzodiazepines.
Mhm.
Um, and I do think that they have a valuable and important perspective on the evidence. But as with anything, I think that everybody can kind of become biased by their own professional experiences with dealing with patients,
Mhm.
as well as looking at the evidence in one way through our own kind of lens of what we're how we're approaching healthcare.
Yeah.
What really kind of inspired me was my work with the Alliance for Benzodiazepine Best Practices, really understanding and learning from some of my fellow professionals on there, uh, Dr. Stephen Wright, Dr. Alexis Ritvo, a number of the psychiatrists and physician advisors, and my fellow pharmacists that are on there. But most importantly, also understanding and hearing the patient perspective and realizing that some of these protracted withdrawal issues or issues of even um, maybe mild cognitive impairment and things that are happening in people's daily lives, or where we've sustained anxiety even from potentially a benzodiazepine with where it's no longer being useful. Some of these things were counter to what the ITFB, the general kind of perspective that they were putting forth.
Mhm.
Now, um, in my critique, I kind of summarize what I believe to be four kind of overarching um, themes or um, position statements, I suppose, is one way of putting it.
Yeah.
Uh, and I can maybe read them out just so that people can kind of get a sense, because I don't want to misspeak or I don't want to necessarily misrepresent the ITFB. I think that there can be an opportunity maybe in the future for uh, groups to come together and share perspectives in terms of finding kind of a way forward
Mhm.
on some of the controversies on benzodiazepines. For the audience, essentially, the core thing that you should maybe know is that the ITFB believes that benzodiazepines have been maligned by the a lot of the medical writers and researchers in the last 2 decades or longer, and that we have had a biased perspective within the entire scientific literature that they are more dangerous than they actually are,
Mm.
that they are that fear of benzodiazepines and stigmatization of them is resulting in underprescribing in some situations where they could be useful, especially for long-term anxiety issues, such as panic disorder. And I believe that in select circumstances, that very well could be the case.
Do they mean, just to interrupt quickly, do they mean intermittently for panic, or do they mean chronic long-term use?
In some cases, I believe it's chronic. Like there was one trial, and um, this clonazepam has the most evidence of benzodiazepines for longer term use. There have been some naturalistic kind of longer term. I believe they were open label studies of clonazepam looking at outcomes on rating scales for panic disorder. Um, it's been a while since I read these papers, but one was from a very prominent and respected psychiatrist, I think in Brazil, and Antonio Nardi, um, and it showed very kind of comparative tolerability with paroxetine.
Mhm.
So part of my critique was kind of mentioning that clonazepam has a very long half-life. Paroxetine is one of the antidepressants that has the greatest rate of withdrawal reactions. So it might not have been a fair comparison. But nonetheless, like I do think that there might be occasions where clonazepam might be successfully used long-term in patients with very refractory or very severe panic disorder, or other variant anxiety disorder conditions. But I guess the critique kind of comes from a place of promulgating this evidence, and then trying to, I guess, maybe justify that benzodiazepines, that the rest of the scientific community has been overzealous or wrong about benzodiazepines, and that we should kind of return to the evidence. I feel that authoring collectively editorials on that and making pronouncements on the evidence is a bit of an overreach, even for academic psychiatrists and people that are experts. And I do believe that a number of the facts and perspectives in their editorial papers from the International Task Force were justified, but I do think at the same time that some of these claims are not substantiated. So if anybody in the audience is interested, the critique can be maybe linked, or I believe it was already linked by in the show notes, but you
Yeah,
can
we'll
read
definitely, we'll put it
Yeah.
below for everybody.
And I'm happy to respond both to members of the ITFB, maybe work with them behind the scenes and improve a way forward collaboratively. I've learned from them in the past, and I also think that if any of the audience members think that I've got anything kind of wrong in my critique, that's something for me to consider moving forward as a junior career investigator and professional in my own right. Part of my speculation here about where the bias comes in with clinician prescribers and especially maybe academic psychiatrists is that they've likely dealt with the most ill of psychiatric patients. And there is a greater likelihood that in those situations, benzodiazepines will be successful and that those patients will need them. So there could be a natural experiential bias that results from patients in those care settings that need longer term benzodiazepines, that them framing in their mind that these drugs aren't necessarily nearly as bad, and then that getting kind of promulgated to a primary care audience, and a primary care audience that maybe sees patients that aren't nearly as psychiatrically ill or have as severe maybe comorbidities or complexities in their mental health, that might justify a primary care provider keeping somebody on a benzodiazepine far longer than they should.
Yeah.
So I think it's really just striking the right balance.
Right.
As with anything with psychotropics, I think after the probably I'm estimating, I don't know how many interviews you've done, maybe 100, but I think probably a recurrent theme is striking the right balance.
Yes.
And part of me launching this critique was, in essence, just to do exactly that: strike the right balance so that people can think twice about benzodiazepines either being too harmful or not as harmful as we thought. so that we can all kind of come together for a consensus on what the evidence actually says.
Yeah. One thing that came to mind, and maybe this is my own bias as somebody who was harmed by these medications,
Sure,
as you say, we
absolutely.
all have our own biases, right? How we see these
But
things.
they're also very valid as
Yeah.
well. So, I only see things from my perspective as a pharmacist as well. So I'm always willing to kind of keep an open mind. But
Yeah.
and I believe the ITFB generally is as well. I have no reason to doubt that.
Yeah. But you were saying that they maybe have an experience with some of the sicker patients. And so it seems perhaps that the drugs are working great in that population, or it is working great in that
Yeah.
population. But I wonder, like, just looking back, in my own experience, how I deteriorated on the drugs and because of the drugs. And that was viewed as severe and worsening so-called mental illness. So is there a
Yes.
way in some of these, trials and the way that we're sussing out the evidence and stuff to sort of separate like who truly is falling into those categories and who are we misdiagnosing because they're having severe adverse drug effects that we think are mental illness?
That's a great question, Nicole. I think that when we try to plan trials and use a rigorous methodology for patient assessment in our protocols,
Mhm.
those questions can begin to be answered. And instead of, say, as you maybe infer, the obvious next step as being a dose increase, maybe there can be kind of a random, like almost like an embedded trial at that point where some patients will either maybe get a dose increase or a dose decrease and then reassess.
Mhm.
Um, because yeah, I do think that part of the complexity and the difficulty is misattribution of certain symptoms as being part of the constellation of their psychiatric illness, or is it part of the constellation of iatrogenic issues from the medication,
Yeah.
whether it's withdrawal or whether it is dependency, or how it's affecting them.
Mhm.
Like benzodiazepines can also in a number of patients worsen mood, right? So seeing that for a patient with comorbid depression and anxiety, and then thinking, oh, their anxiety is still there and they're feeling more depressed, let's increase the benzodiazepine. There are many of these unique circumstances that I think patients and providers face on a regular basis, and it isn't always clear, and it's often left up to judgment.
Yeah.
But I think you raise an excellent point. I don't know exactly how that would be, if there are any trials that are currently ongoing that are going to look at that per se.
Yeah. So, I'm just wondering then if there's all this sort of controversy, right? The
Hmm.
FDA has put out a black box warning on the
Yeah,
benzodiazepines. Actually, well, I don't know if you
I
say
think
it was two. They had one and
there's
then
been
they
two.
updated it. Yeah.
That's right. Yes.
And then you have this international task force that's saying, like, hold on, this is, the benzos are being maligned. I have somewhere a recording of Dr. Alan Francis. You may know who he is,
Yes. Yeah. And
saying
he
like
actually.
benzos are pretty much
Mhm.
useless in anybody was a direct quote from him. So
Yeah.
it's like, I'm just thinking of the average patient, of which,
Mhm.
I sort of used to be, even though I had medical training. So somebody was even
Sure.
no medical training, just a regular person who gets this prescription for a benzo or a Z drug. Like, how in the world are they meant to weigh the risk?
To navigate it, to
Yeah.
navigate their, yeah. I think that's an excellent question, and I really do think that it is being self-aware and training patients to be self-aware of how they're feeling on their medication and bringing it up to their providers early. And if you can't reach your provider, work with a good pharmacist who can, and who can maybe help to identify some of these issues at an early stage, so that we can prevent or mitigate longer term harm by keeping a person on it indefinitely or longer than they should. But I do believe, like, I'm an admirer of Dr. Alan Francis. He came to Manitoba and he spoke at one of our conferences, and uh, I don't. I slightly disagree with him on that. I do think that benzodiazepines are not useless. They're far from useless. They're very effective medications for acute circumstances, and also for short-term management of kind of crisis anxiety, and in maybe select, very carefully screened patients, maybe for longer term use. But the way that they are often being used, it is simply not ideal.
Yeah.
So how do we empower patients to make even to first become aware of how they feel on their medications, but then also encourage plans for non-pharmacologic behavior changes, whether it is cognitive behavioral therapy for insomnia, whether it is sleep hygiene changes, whether it is exposure, mild kind of increasing exposure therapy for anxiety issues or phobias. There are a number of other modalities that people can try and rely on. So I think that when possible, do those things. That's my perspective, but only as a pharmacist, not as a practitioner. And then ensure that the medications are being used very, very judiciously.
Okay.
That makes sense.
Oh, yeah. So I guess that would be, my next question was kind of, what is your best advice to someone either considering starting a benzo, or let's say somebody who's already on them and they've been on them for a significant amount of time?
Yeah. So the advice would vary quite a bit for both of those individuals. The first person that is considering being on them, I would say, ask yourself what the plan is and what the exit strategy is. Determine kind of your clear outcomes from what you want from the medication, and ensure that you have a strategy for successfully discontinuing it. Ideally, in most situations, you should maybe be on it no longer than 2 weeks, maybe a month. The longer you're on it, the greater it will increase your risk for physical dependency. Understand that there is no stigma with physical dependency, or that there shouldn't be anyway. And just like there shouldn't be a stigma with addiction, but the issue with benzos, I think, and it's likely been talked about at length with some of your other guests, is that it's rarely true use disorder or true addictive disorder as it is physical dependence. But when symptoms like that emerge, be aware of what they might be, and talk to your pharmacist or your doctor both, and develop a strategy for facilitating your care in light of that, and how to maybe get you off of it, or at a much lower stable dose, maybe on an as needed basis. If you use medication as needed, it really should be thought about carefully for when you need it, because the whole stigma also of the pill popping patient, it's a very negative stigma, but I do think that there is a tendency for certain people's behaviors to reach for the pill bottle. So if you find yourself as maybe potentially being one of those individuals, or yourself to be one of those people, work with your doctor and pharmacist to ensure that there is kind of a contingency plan, or like a management strategy, so that you're not overusing your as needed benzodiazepine.
Yeah.
And then for the second patient, I know I've talked at length there. The first,
oh no, you're fine.
For the second person, the person that's been on it for a very long period, develop a tapering plan, but really try to place your benzodiazepine within your life context. What role is it currently serving in terms of maintaining your kind of physical stability, almost, whether it be like a coping mechanism, or just preventing withdrawal symptoms from occurring? And then work with your pharmacist or doctor to kind of develop an individualized plan that is right for you and your life circumstances, such that we can do a slow taper, and do it. I've been able to successfully taper a number of patients, but it can take a very long time. Sometimes it can take over a year, sometimes closer to 2 years. And there are times where patients have come to me and they said, "Oh, I'm not ready for the next dose reduction. I have my family is coming into town, or I have to go to a funeral or something is happening and I'm worried about the possibility of what this dose reduction will be like for me in the current circumstances.
Yeah.
And that's fine. I've been able to advocate for them and get kind of an extension for their current dose. A good advice is to always really do a careful reevaluation if you're going backwards. So the doses really shouldn't increase if possible. Inevitably, that might happen if you're having severe withdrawal, but that shouldn't happen with a good tapering plan.
Yeah.
So if you're wanting to increase your dose, we should talk about that and really try to work with your pharmacist and doctor for maybe redefining what the goals of therapy are. But staying at a dose is fine, and doing kind of a gradual taper. We're there, I think, to support you. It's very similar. I think it's akin to, in some ways, quitting cigarettes. It's not entirely the same. They're very different medications, but patients need the same type of psychosocial support in some circumstances. And it's just the benzodiazepines have been far more medicalized. But the dependency, and of course, one is a stimulant, one is a CNS depressant, but nonetheless, we can use some of those same strategies that we do for tobacco cessation as with benzodiazepines. I think that they're somewhat transferable, even though they're different drugs, different compounds.
Yeah. Okay. I just want to ask, do you have a hard stop here in a few minutes, or can you stay a little over?
I'm happy to stay on for a bit longer. I've really enjoyed this interview.
Okay, great. We just have a couple audience questions too that I want to get to if you have time.
Yeah, absolutely. I'm happy to.
Okay. So I think it's important to ask, you said you spend some time helping people discontinue these medications. And one of my personal pet peeves that I've seen a lot is physicians who know that there's issue with benzodiazepines. So maybe they're doing a presentation or something on benzos and all the risks and harms, but just very nonchalantly. And I know that this is the standard of care currently, is to say that SSRIs or SNRIs are safer first line alternative. But then there's no informed consent, asterisk after that saying, but SSRIs can also cause physical dependence and withdrawal syndromes in
Absolutely.
people. And so I'm wondering, how much of that are you seeing in your practice?
Yeah, that's a great question. I do see instances of that as well. I think that I am perhaps slightly, and this is maybe where my own kind of experiential bias comes in, because I have worked with patients with antidepressants. It's very common, perhaps more common than with benzodiazepines. But I think that as clinicians, and I do think that maybe this is where I would, in extending an olive branch to the ITFB, part of their criticisms about the way that benzodiazepines are framed compared to antidepressants is accurate. They believe that the terminology has been a little bit more negatively construed for benzodiazepines than for antidepressants. We talk about traditionally or conventionally an antidepressant discontinuation syndrome, but not antidepressant withdrawal. Yet we talk about benzodiazepine withdrawal. So I think that you're exactly well on point, and I do think that kind of gives me an opportunity to also applaud the ITFB in bringing that to the forefront. I do think that there have been many instances where I work with patients with wanting to discontinue an antidepressant as well. Sometimes this results in them stabilizing at a lower dose, or doing kind of a cross taper to another antidepressant if need be, because sometimes they lose their efficacy after patients have been stable on them for years. But managing the withdrawal syndromes associated with that is also a matter of complexity, and one that I'm not as much of an expert on as I am with benzodiazepines. But I think that the two go hand in hand, and if anything, don't try tapering both at the same time. Don't try to be making multiple medication changes at the same time unless it's urgently necessary or you're in an inpatient setting where more careful monitoring can occur. because I do think that you run the risk of not only causing greater harm, but also causing greater confusion for determining what medication resulted in what happening
Mhm.
to your body if you're making those multiple changes at the same time.
Yeah, so that was an audience question. Somebody wanted to know if you
Did
had
I
a
did I answer it? I felt like I
yeah,
maybe danced around the question. I want to make
no,
sure I
no, but
answer.
they wanted to know if you had an opinion on, okay, someone's a polypharmacy patient, and let's say they're on an antidepressant and an benzodiazepine, and they want off both. What would you advise
Well,
usually?
what I might prioritize will to some extent vary, and it might depend on how the patient is presenting and maybe what adverse outcomes or side effects, so to speak, that they're complaining about the most. So identifying the culprit medication first, or the one of highest priority, and then focusing on that. But really trusting our patients, if they really think that the antidepressant is causing more of an issue, trying to focus on that, though I do think that it doesn't look as good on a patient chart for most primary care providers when they see a patient being tapered off a benzodiazepine and just remaining, or being tapered off an antidepressant and just remaining on a benzodiazepine. So I think that often requires a little bit more justification. I'm not saying never do that and that can't be done, but it would, because of the way that mental health is managed with medication currently, I think that it'll more likely raise red flags than the reverse.
Right.
So just be prepared as patients. If you're wanting to come off your antidepressant but stay on your benzodiazepine, you might encounter more clinician resistance to that than the opposite.
Yeah. Even though maybe technically it might make more sense, like
It might,
yeah,
I'd have to really understand the patient case and the dynamics to
yeah.
but
So there's
yeah,
politics
there's a
at play,
possibility.
basically. Yeah.
Oh, for sure,
Yeah.
absolutely. It's
Yeah.
a good question, though. I appreciated that.
Yeah, sure. So this person wants to know, how many people do you think are really getting true informed consent with benzos and Z drugs at the time of prescription?
I don't think I can put probably a proportion percentage on it, other than saying not enough.
Yeah.
Not enough patients are. Um, I would be curious if that has been studied maybe in a patient survey, and doing kind of a targeted literature search, you might be able to encounter something, but I don't know to what extent. In terms of signing informed consent papers, I'd say that is very uncommon, at least in my jurisdiction.
Mhm.
It might become increasingly common in other jurisdictions where the focus on benzodiazepine related harms is becoming more recognizable. And then policies are being implemented at different kind of, whether it's at a clinic level or at a health systems level, or even at like a regulatory level, where now doctors are required to get informed consent. But if it's up to doctors and pharmacists to just be doing this, I would say in most circumstances, you shouldn't expect an informed consent document. But we do have resources through the Alliance for Benzodiazepine Best Practices. You can find tools and conversation starters on how to talk to your patients or how to talk to your doctors about benzodiazepines. So, I encourage audience members to check out our website on that, and it could be, hopefully it'll improve. That's all I can say.
Yeah. Okay. And then I'm wondering, just sort of as a last question, what kind of research, if any, let's say you had all the money in the world to design something around benzos and Z drugs, what questions do we need answered?
If I had like an infinite budget or something like that for,
Wouldn't that be nice, right?
yeah, I think at least from my early kind of research agenda from my thesis, determining with a higher level of certainty whether benzodiazepines are increasing dementia, or if they are causing immune-mediated changes that are maybe increasing or slightly increasing people's infection risk. Really determining things like that would be useful. Also, some of the, I think another critical and important thing is more longer term kind of chronic research on longer term use and the effects of it after patients have come off their drug.
Mhm.
So the kind of the emerging clinical construct of bind or benzodiazepine induced neurological dysfunction, I think more research funding into investigating whether that is um, a real phenomena. And I'm not saying it isn't, but it needs to be kind of more understood, and only further high quality research will bring it to the forefront for patients that have suffered from that, so
Yeah.
that more clinicians can recognize and learn how to deal with it, and then how to treat it.
Mhm.
Even after the benzos are gone, it might require very different approaches for how to manage the long-standing symptoms of that.
Yeah. And could we ever tell people definitively, will it go away? Or,
Right. Or what are the probabilities that it might go away for one person compared to another? It could be maybe over time, with enough accumulation of evidence determining people's risk scores or the prognosis for these things happening in
Mhm.
certain patients. And that could be looking at other types of research that are well outside of my scope, whether it is genetic research, or um, more kind of targeted brain research that looks at maybe where benzodiazepine are maybe working in ways that we never really understood.
Mhm.
So yeah, I think that there's thoughts on the horizon for a broader research agenda in the years that follow. And I think that there are many important scientists and clinician researchers that are interested in this and are probably doing work on it.
Yeah. I mean, imagine if we could just know ahead of time who would,
Yeah,
have
and that's
a bad
exactly.
time. Yeah, that'd be a great thing.
It would be, yeah, certainly. And I know that there's ways of doing that kind of prognostic evaluation for other kind of disease states or even other medications, but I don't believe it exists in a very strong way for benzodiazepines or for really antidepressants at a high level in that regard either. So
Yeah. Okay, so I think we'll go ahead and close here. And I'm just wondering, if you have any closing thoughts for anybody listening, resources. I know you mentioned the Alliance.
yeah, I
You wanna-
mean,
Yeah.
yeah, I would say the alliance is excellent. I would definitely recommend this book if you haven't heard of it, The Benzodiazepines Crisis by Oxford Press, and it is written by a number kind of collaboratively and edited by experts on benzodiazepines. So it's a good starting point for many people to kind of delve into it. It isn't necessarily fully written for a layperson audience, but there's something that anybody can learn from that book on benzodiazepines. So
Okay. And if people want to, read more of your research work or that kind of thing, is there like a centralized location they can
if you
find it?
if yeah, I mean, if you want, you can type up my name, Jaden Brandt, on Google Scholar. It has all of my work readily on there. I think you might also provide my email in so I'm happy to take emails and from people that have questions pertaining to this topic or to the talk that Nicole and I have had.
Okay.
I'm always excited to learn and engage from both patients and other health professionals.
Okay.
So
Awesome. Well, thank you so much for joining us for this live discussion. If you
thank you
have
so
not,
much.
yeah, sure. If people want to see the film Medicating Normal and they haven't seen it yet, they can go to medicatingnormal.com/watch, where they can find the many ways that they can view it. And if you want to know about upcoming interviews like this one, you can check our events tab on Facebook. So thanks again, Jaden, and thanks everybody for tuning in, and we'll see you soon.
Thank you very much, Nicole. It's been
Yeah.
a privilege. Thanks.
Yeah. Thank you for joining me. Bye-bye.
It's
Take
been my
care.
pleasure. Thank you.